Hi everyone, my name is Ron McCulloch and I'm a consultant podiatric surgeon specializing in the conditions of Morton's neuroma. And as many of you will know, we offer a number of very refined treatments within our center, which include radiofrequency and particularly cryosurgery. And these techniques are generally used before we consider anything more extensive like open surgery. However, there are times when open surgery is appropriate, and other videos cover the reasons why. What I really just want to talk about here is how can you maximize your chances of having a good result from open surgery? What should you be aware of in this regard? So there's a lot to cover here, and I think I'm just going to talk about some of the key points, and other videos will cover other aspects. But if we think about it logically, the first thing is the incision. Now, some patients scar more than others. If you have a reactive skin type and you scar very easily, then that worsens your prognosis with regards to the treatment of Morton's neuroma through an open procedure. What you need to bear in mind is that if your skin is scarring excessively, the likelihood is that you're also getting more internal scarring. Okay. Now, the question is, what can we do about that? So the key point is, if you have a reactive skin type, a skin type that easily scars, then the situation is that you will also get more deeper scarring inside your foot, and all of that can lead to fibrosis around where the nerve's been cut and increase the complication rate. So what can we do about this? Well, the first thing to think about is the incision. Now, what we try to do is a curvilinear incision on the top of the foot, not the bottom, on the top of the foot, and by doing that the risk of scarring can diminish, because in areas you are following the relaxed skin tension lines, which can help with scar formation. The second thing is that your surgeon has to use meticulous techniques whereby any vessels that are encountered are closely closed off, either with electrocautery, which is a small burning device, or perhaps even tied, although electrocautery is better because you don't want to leave any internal sutures in, or at least any more internal sutures in than you need to. But needless to say, the surgeon needs to have a lot of experience and be able to dissect the nerve out effectively and ensure, again, that deeper vessels are all closed down so that there is minimal bleeding in the area, because that's what causes a lot of the scarring. Now, in terms of closure, this is also very important. What we tend to recommend with reactive skin types is that the internal sutures, the stitches inside your foot, are kept to a minimum, because that undoubtedly can cause some scar tissue and collagen buildup to occur. But also with regards to the skin, we will often use absorbable sutures and stitching, but in instances where we think there might be a more chance of a reactive scar, we will generally use non-absorbable sutures, which can be pulled out, and then we know later on they're not going to cause any issues. And just finally, with regards to the actual skin, we start very early treatment with silicone dressings. There's something called Sika dressings from Smith & Nephew, and these are excellent. And if these are applied early as possible after these stitches have been removed, then this can really help to minimize scar formation, at least in relation to the skin. Another thing is, how is the incision done? Should it be done through the top of the foot or the bottom of the foot? Well, fundamentally, in my view, it should be done through the top of the foot, not the bottom. And there's a simple reason for that, and that is the fact that you are potentially going to get a scar underneath your foot, and as a consequence, that scar can then become a real source of pain, easily as bad as the neuroma. So there'd be no reason to do a incision underneath the foot unless it was revision surgery. Now, there are some surgeons who would argue that the risk of scarring can be mitigated by keeping the patient non-weight bearing afterwards, but that has its own risks. If you keep the patient non-weight bearing afterwards, need to use crutches, they're more likely to damage or injure their shoulders and so on. It's just unnecessary. And even with a non-weight bearing approach and the additional risk of thrombosis and so on by doing that, ultimately, there's still an increased chance of scarring underneath the foot when compared to a dorsal incision. More to the point, the scar is much more likely to cause irritation because, of course, you don't walk on the top of your foot, so therefore it's less of an issue anyway. Some surgeons will argue that they have very few issues with scarring and that therefore there is a justification going through the bottom of the foot, basically because the nerve is easier to find because it's much nearer to the bottom of the foot than the top. But my counter argument to that would be a simple one. Even if you operate on 70 or 80 patients and only 1 or 2 of them have a troublesome scar, that's still one patient that has been left with a complication that could have been avoided by going through and doing a dorsal incision. So I really don't personally feel that plantar incisions going through the bottom of the foot when doing open surgery for Morton's neuroma is really the right way to go about these things. Another thing that really maximizes the chances of success is minimizing bleeding. So obviously if you have a tendency to bleed, that needs to be very carefully thought about anyway. It's very much up to the surgeon to make sure that he uses meticulous hemostasis, he uses techniques to minimize swelling and bleeding, and that's all about good surgical technique. But afterwards, it's very important that you maintain with your foot elevated during the recovery period, and certainly for the first week I encourage my patients to keep their foot elevated as much as possible above their hip at minimum, and ideally above their heart level. Now that doesn't mean being completely immobile. It's very important that patients have a degree of mobility to avoid thrombosis and other complications, and of course some mobility will actually encourage blood flow and fluid back to the heart. But that mobility is generally done through specific exercises that our physiotherapy team teach and demonstrate, whereby the foot can be elevated and mobilized in various ways to maintain muscle activity. Another thing that is often discussed in relation to the success of Morton's neuroma surgery is how the nerve is cut. Certainly it needs to be cut back to where the tissues are healthy and where the nerve isn't in any way thickened. Some surgeons will talk about and state that they will bury the nerve either in a muscle or even in bone. And in my view, this is unnecessary and actually more likely to cause complications. The reason for that is that if you're going to try and do that through a dorsal approach, you have to leave the nerve somewhat longer, and I think that in itself will cause issues. I also think if you try and bury a nerve into a muscle as soon as the foot moves, it won't stay there. If you sutured it in, there's more risk of stump neuroma, and the same is true of trying to put it into a bony tissue. So I personally don't think it's practical. If you're going through the bottom of the foot for a plantar incision, for example, for a revision where you've got a stump neuroma, then there is more opportunity to try and bury the nerve because you can get further back. But again, I have serious doubts as to whether that will afford any real benefit. And my concern is that it may actually encourage some irritation of the nerve, especially if the attempts are made to suture it in place. Another question that's often asked in relation to open procedure is, should I have the ligament released? Now, some of you will probably be aware that in some cases the ligament is released in isolation and nothing else is done other than that. And there are sometimes reasons to do that, but there are some negatives, and that will be discussed in another video. But the key point is, in relation to removing the nerve, you have the option of leaving this ligament, what's called the intermetatarsal ligament, in place, or you can cut through it. And the question is, which should you do? Well, that is not a black and white question. Basically, if the ligament is fairly loose and doesn't seem to be causing any major issues, then we would leave it in place, because there is a risk when you cut through the ligament that the foot will splay, and that may cause and can cause, and I have seen this, some issues with the intrinsic muscles, the small muscles that control the toe, and you can get some deformity as a consequence. After all, the ligament's there for a reason, so clearly you'd want to have a reason to remove it. However, when the ligament is very tight and bound down and you think it's a real hindrance to recovery, then sometimes we do cut through it because the pros outweigh the cons. But I will often remove a neuroma without necessarily removing or cutting through the ligament. It just depends on the specific circumstances of the patient.